You are listening to The Dish on Health IT, brought to you by Point of Care Partners, a leading health IT consultancy. Each episode will feature a rotating panel of senior consultants and guests who will talk about trends and innovations in health IT, while also highlighting how organizations can leverage these advances to solve their business problems. This special episode of The Dish on Health IT will cover themes and highlights of the HIMSS24 conference. Hosts Pooja Babbrah and Jocelyn Keegan give their perspectives and observations of HIMSS before reacting to brief interviews we captured in the Interoperability Showcase. We spoke with health IT leaders on topics ranging from the CMS prior authorization rule, API adoption, and pharmacy interoperability. We hope you enjoy this special episode. Remember, if you have topic ideas you'd like us to cover in future episodes, be sure to share them with us by emailing us at podcast@pocp.com or tweeting us at POCPHIT.
My favorite thing about coming to HIMSS is definitely the collaboration that happens and the conversations that happen.
So the highlights of HIMSS for me, it is always year after year a great platform for finding the right collaborators and the right ways to engage with different vendors and representatives of different spaces within healthcare. It is super informative.
Well, conferences like HIMSS are a great place to see the innovation that's happening in the marketplace.
Hello, everyone, and welcome to The Dish on Health IT, where we invite health IT innovators and catalysts to break down and discuss some of health IT's biggest news and most exciting milestones. We at Point of Care Partners are health IT consultants who work with stakeholders across the healthcare ecosystem and are viewed as independent, objective, trusted party like Switzerland. I'm Pooja Babbrah, the pharmacy and PBM lead here at Point of Care Partners, and I'll be your host for this episode. Joining me today is my co-host, Jocelyn Keegan. We're going to be discussing the key takeaways and insights from the HIMSS24 conference last week. We also had the opportunity to present and speak to some of the attendees of the sessions. We got to engage with some of the folks who came by our Point of Care Partners kiosk and also listen to their perspectives on some of the most pressing issues in health IT. So we did have a couple folks come by the kiosk for interviews, and we asked them their thoughts on various topics from the CMS final rule on prior auth, the shift to APIs, artificial intelligence, and of course, my favorite topic, pharmacy interoperability. For our episode today, I thought we'd talk about our overall observations of HIMSS24, both positive and negative, and then react to some of the responses we got during our word on the street interviews at HIMSS. So first, I thought we'd share our big observations and some of the themes that we saw at HIMSS last week. So Joss, you want to go ahead and start?
Yeah, so great to be here. And last week was a whirlwind for sure. I was in and out in 3 days, so there was a lot packed in. But there were a few, I think, sort of high-level themes I think we can sort of unpack as we go through today's conversations and hear what some of our colleagues have to say. But, the first, I think, coming off of both Vive and HIMSS, one of the big takeaways that I think, or ahas I had over the course of the week was, that we really have been talking about connecting really for about 15 years now, right? How are we digitizing and getting people connected to each other? And I don't want to oversimplify how hard that was by any means, but I think we're now at this point in time where we really should be focused on the content. I use the phrase like, let's get to the good stuff, right? This is really about how we make sure that everybody has a way to connect, and it might not be universally the same, but that everybody's got an on-ramp. And we've got a future, right, where we're headed towards with APIs, but that, what do we do today with today technology to get people started and meet them where they are so that we can get everybody to that future? And that really is going to be about the content and the use cases and really solving these real world business problems. That's where we're seeing people make investments and sort of get the funding and time to do this work. The second one that I think is adjacent to that, which was a little bit of a reflection for me in sort of my own sort of arc of my career. I have a degree from a liberal arts university in history, and I worked in this first wave of moving to information and data sort of flowing in the mid to late 90s. And that at that point in time in financial services, we really had to build the people to do that work. The company I worked for hired a bunch of people like me, right, that knew how to think and had critical thinking skills and sort of could do abstraction and built us as information technology professionals. And I think that we're at a crossroads here. I think we have informaticists, and we could use more sort of people that have that clinical and informatics sort of combined view of the world. And we have got really strong technology, but how do we get the people that are actually doing the work and operationally, what we would have called in the late 90s knowledge workers, sort of built because they don't exist, right? We literally have to create this wave of people inside of our own organizations, and we need to train people and help them understand a lot of the concepts around data and data mapping and why we clean data, and really sort of, I'd say, sort of the respect for data. And I think that was another sort of aha, right? That we have this, how are we, both our federal partners, the standards organizations, and us in our own organizations, building this next wave of people to do this work for the next 20, 30 years. And then the piece that sort of follows on from that is, how are we leveraging sort of this investment in technology and the level setting that the move to APIs gets us, and the network of networks and TEFCA becoming real, and that role of the EHR, but then also the ability for people to self-serve either from their own data warehouses or from other intermediaries that couldn't get into workflow before. So we're really going to get to this point in time that we're at this place where we really people really need to figure out sort of where they're going to fit into the puzzle. And we could see that from a vendor community perspective, from some of the early storytelling that's happening at HIMSS that was real in a way that I hadn't seen in previous years, which gets back to sort of, the volume, I would say, and the noise of people talking about the impact of the rules of TEFCA, and people talking about being FHIR and TEFCA enabled sort of in their booths, in their talk tracks, talking about sort of the role of implementation guides is markedly different. And then lastly, I would say sort of on the buzz front, I know I always sound like a negative Nelly when we talk about artificial intelligence. I think this idea that, I think that the bubble is bursting a little bit, and people are really fundamentally understanding that in order to really use technology like AI, that we really need to focus on data and data quality, and that you could hear people that were sort of early adopters or the vendors that are out there working, sort of on test cases and proof points, really focusing on sort of people understanding sort of this underlying data quality being important to us.
Yeah, no, those are great points. And just to kind of add, I think you started with kind of Vive and HIMSS. I think, the one thing I kept seeing is, are they both going to survive, right? And I think they're very different, of course, some of the same people, but kind of different audiences, right? And different ways to approach it. So I do think both are going to survive. I want to go back to your first 2 points of the content. I think what, this whole idea of this data tsunami, right? There's so much information now that we can share, but like, what's the right content to the right people? So not everyone's going to need everything. And I think that what I heard was a lot of discussion about, hey, all this information is out there. How do we make sure that we're, not overwhelming people, and then getting the right content to the right people? And I also think the point about meet people where they are, I mean, we clearly heard that in our long-term post-acute care listening session, and some of the sessions that I went to of, not everyone is FHIR enabled, not everyone's, doing everything, using APIs. So what do we have? What are the standards? What are the tools we have in place today that can help people exchange data, even if they're not all the way at the, the tippy end of the spear? So I think that's really important too. And a lot of what I heard in kind of the discussions I was having. So
I think that's a really important point, that really everybody's someplace on a spectrum, right? Aren't we all somewhere in life, right? And I think that when we think about that, it's sort of how do you meet people? But I think there's another important point that's underlying this, I think that you're teasing at, which is this idea that it really is about how do you get the right information with the right consent. And I wanted to tease on that because I feel like for the first time and I just got a note from the FAST team this past week that they're officially kicking off the consent use case, that there was a lot of really good discussion about sort of this barrier, not just on people that already have business relationships that are doing things in a more manual way or in a more paper-based or document-based way today, really tackling that. What does it really mean to just share just enough data and no more to the right person with the right consent and the right governance and data use policies in place? And I think that people are starting to grapple with that inside their own organizations. Both, we're just sharing the existing data we already share more efficiently and maybe less of it, right? Sort of that climb that people need to go through, to the, hey, if we're going to have this tsunami, what are we doing to put the rails in place so that we're protecting us as patients and making sure that only the data that needs to be shared is being shared and not your entire clinical record. So
yeah, definitely. And, I participated in that kind of the second annual consent workshop that Swords of Change did. And you could see the shift between last year and this year. And, for one thing, we had regulators in the room, right, who were actually talking about this and saying it. But, the conversation was more about what are people actually doing in California and Broward County and Florida. And even beyond just our medical data, it's all about, the human, if you think about HHS, right, it's Health and Human Services.
Right.
So it's everything beyond that: education system, juvenile system, the prison system, in addition to our medical record. So absolutely so much to tackle around that. I think, like you said, right, we've got the data, the technology to share the data. Now, what is it that we're having to do to kind of bring folks up to speed, and what are the things that we need to put in place in order for that data sharing? So
yeah, I think that's important.
Great. Yes. All right. So let's take a look. Want to dive into look at what some of the people who came by the kiosk told us at HIMSS. So I think let's start with first listening to a couple of folks telling us about their thoughts about the CMS interoperability and PA rule.
Hey, Colin Banis, Chief Medical Officer for Dr. First. So commenting on health IT policy and CMS interoperability and prior authorization, it's definitely a step in the right direction. It's a long time coming. As I often say, when the private sector doesn't get it right, eventually the government steps in to nudge us along and provide the direction. Dr. First's main focus is on medication management. So it is a little disappointing to not see medication prior authorization get the spotlight that it truly deserves. We can have a debate on why that is, but hopefully it's soon to follow. Dr. First is working very hard on reducing the friction related to prior authorization and specialty prescribing, so very near and dear to my heart. But as I mentioned, this is a step in the right direction. We're finally getting some momentum and we're finally getting some adoption. A lot of us would say it's not fast enough, but hey, it's movement forward.
Okay.
I love that. I love that because Colin's totally talking to my soul, right?
Do you think that he listened to our conversation that we've been having? So yeah, CMS did leave out specialty meds, but they also recognized, I think, in every single talk that I heard, that when they were talking about the prior auth rule, that they just didn't have enough information on it. So I'm pretty grateful that they're now starting to, I think, do the necessary research, because we don't want them to actually do policy in a vacuum, right? So I think the fact that they read the comments, that there is a lot to unpack around specialty when it comes to prior auth, and you can't just, put it with everything else, is great. So I think he has been listening to our conversation.
Yeah. I think it's great. And I do think we heard this reverb a lot, right? Because I think that often these meds are the ones that are the most critical to the patients that are most in need. And, you and I have done tons of conversations, right, about just the sort of the time to, actually getting on therapy, or not even ever getting on therapy because of the complexity of, getting prescribed, enrolled, and then approved for many of these medications. So I do think, and I agree, I think when you hear somebody from the CMS team talking about this, they acknowledge that they know that it is a gap, and that they didn't want to stop progress, right, to sort of pull it back in, because that could have pushed out all of our timelines. But I think I view it that we're getting started, and this is a space. I'm channeling my inner Kim Boyd right now. There is nothing in the existing regs that say that you can't use the FHIR APIs to solve specialty medication that's on medical benefit, which would be really logical. And I feel like there's a little bit of an awakening too of the rest of the industry understanding the advancements that we've had. While pharmacy prior auth isn't perfect, it's working at a scale, and that we should take advantage of that and the learnings from what pharmacy has instituted, right? They don't dispense stuff till they know they're going to get paid. As a patient, you understand pretty quickly what your requirements are or what your options are from a formulary and benefit perspective. Again, not perfect, but way better than we are on the medical prior authorization front these days. So I think it's important for people to keep talking about it, and to lead and show by example how this work is going to actually be accomplished ahead of the feds telling us what we have to do.
Yeah, and I think it goes back to your comment of not everything has to be in the EHR, because what I've been hearing lately about even pharmacy prior auth is, we tried to integrate it into the EHR and have the provider do it, and that's just not working necessarily. So the fact that pharmacies can kick off the prior authorization for a provider is a huge step forward, because we know that the physicians, we're trying to put everything in the EHR. Now let's try to do it in maybe systems outside of it where we can actually get things done quicker. So
we could do another hour on this alone, but I think that this is a really important acknowledgement, right? That it is probably not fair to expect the burden of prior authorization to be completely on the provider, because let's be clear, we've talked about this in the past. The provider doesn't get paid for that pharmacy to be dispensed, that pharmacy item to be dispensed. The pharmacy does, and so we're basically putting a tax on providers to do the prior authorization, when often the right clinical information is available to that pharmacist to be able to get that through, and the standard will support it. So, again, I think it's about sort of how are we continuing to evolve and iterate and get better, and acknowledge current workflows, right? And where bodies actually sit and who does the work. So,
yeah. All right. I think we've got another clip on prior auth that we can take a look at.
Hi, everyone. My name is Paulina Wasserman. I'm a VP of Product Management with MHK. I'm here to answer a question about the policies and CMS rules on interoperability within prior authorization space that we've all heard recently about. Historically, the prior authorization has been a very cumbersome and complex process for all the stakeholders involved. It is regularly associated with the reasons for delays in care or quality of care that our patients receive. It does create a set of inconsistent requirements today for different members within a healthcare continuum that result in inconsistent results that our patients experience. So with the new rule proposed by CMS, it opens the horizons of much more iron communications between all the stakeholders in the space of prior authorization by standardizing and streamlining the ways that we all interact on a prior authorization side of requests and responses that come through it, through the continuum of care for the patients. There's a lot of promise in reducing that administrative burden that has been so unfavorable in every aspect of the patient experience through this process. This topic is dear and near to our heart at MHK. We've always been at the forefront of the compliance for the payers that we work with. As a trusted technology partner, our systems have always intended to stay upfront of all the regulation changes to help our payers be compliant with the changes out there that they need to facilitate for their patients. The key to adoption of this new rule, from our perspective, is investing in the right areas of technology that truly bring that collaboration between the stakeholders. It is the standards are only as good as they're adhered to, but with the open channels of communications now prescribed by CMS and the governing body, there's a true opportunity for all the parts of the process involved to kind of facilitate the movement of the data through the process in a way that is timely, in a way that is standard, and provides predictable results for the patients that are expecting those outcomes.
All right, Joss, you want to?
Yeah, so I think that Paulina is great. I think it's getting at the heart of a lot of the conversations and a lot of the sort of talk tracks we heard when folks were demoing or talking about their progress with the early Da Vinci guides. Again, it was a little humbling, I would say, to see how many people that aren't in our sphere or sort of directly related or funding members of Da Vinci to be out there talking about sort of their progress of adopting these guides. I think that that's the heart of this. I think is that in this case, Reg is doing what Reg does, right? It is literally prioritizing roadmap and pipeline of funds to organizations to do this work for real. And I think that we're seeing that, and we heard that last week, and I think we heard that at Vive. Sort of for folks who don't live and breathe this on a day-to-day basis, for the last 2 or 3 years, there's been 50 or 60 people on these prior auth calls every week. There's a new wave of people sort of waking up and paying attention and getting involved. And again, this is about evolving and iterating. And I think that if you sat in some of the audiences and listened to just some of the early storytelling that's happening. I think Availity and Athena and the folks at Humana presented on their early story and experience with automating prior authorization. And I know the MCC and MCG team, Anna Taylor and Raj and members of Heidi Kritz who's been out on the circuit and been really open about their experience to the industry thus far. The benefit sort of, tagging on to, both Colin and Polina's point, the benefit of using standard APIs and acknowledging prior auth as all of these steps is that we're seeing really stupid, simple sort of value returns on making these investments. I think Anna does these presentations where, her and Heidi talk about on both sides of the puzzle, they're getting automated answers or reducing the need for prior authorization and on like almost 80% of the requests. Like that same day, sort of near real time answers to care teams about what their patient, what getting their patient access to a service. And then when they need to do it, seeing literally the ability to do 2 to 3 times the volume of prior auths for patients and getting, turnaround times that are way below even the, updated turnaround times being expected in the CMS rule. So, if people aren't doing this because they're being mandated to it, I think very quickly as people make these investments, they'll see that the business ROI, both on being able to use people at higher, better purpose, sort of in their organization, and just getting patients to their care faster it's gonna pay for itself. So I think that's important.
Absolutely. And I'm going to put a plug in for one of our episodes with Heidi and Anna. They did an amazing job kind of sharing their partnership and the ROI they've seen by implementing this. So I definitely, if you haven't had a chance to listen to that one, definitely worth listening to. All right, let's shift to FHIR APIs. I think we had a couple folks answer some questions on that, so let's take a listen.
Hi, my name is Leif Bigler. I'm Vice President of Clinical Network Services for First Data Bank, and I'm also General Manager of our new FDB Vila e-prescribe e-check. I'm happy to answer the question around FHIR APIs and sort of the healthcare interoperability behind that. I think there's a lot of opportunity to leverage FHIR, especially when it comes to the way that PBMs or payers may be communicating price transparency information directly to a patient. Or even a provider, but I think there are ways that we can access the FHIR APIs, leverage them to improve the information that's being provided to a patient.
All right, another great answer from our pharmacy friends and someone who's probably listening to our conversations again. Real-time benefit check for consumers, yes. Loved Leif's answer on this. The thing is, people don't think about pharmacy and FHIR and APIs, but all the PBMs had to implement FHIR server because of the regs, and so let's utilize it. Let's use that in order to help get information like we were just talking about. Meet people where they are, but then also utilize the tools that we have. And especially for this patient, the price transparency. Again, another topic we could probably go on and on about, but definitely, I think we're seeing also, again, to kind of channel Kim Boyd, we're starting to see states say, hey, you have to do this using FHIR. You have to get this information to the patient. So, so let's just do that. So, any other comments, Joss, on that one?
One comment I would make, I think Leif is a great example of the fact that we're just recognizing that there's other end users, right? And that when you're doing this high cost integration work, you're sort of point to point within individual parts of an organization. And as we move to, more of a structured API world where I can put something in a workflow anywhere, that ability to get to more types of end users of this information and parts of the care team, like pharmacists, like care coordinators, that we're just able to do more faster in more real time. And I think that you can't underlie sort of how important that will be in really allowing us to get to the things that you've just never been able to prioritize within your organization, and people that have been data poor, allowing them to get the right information to be able to make good decisions about patients just in time, and leverage those assets, those sparse resources better. And so I'm really excited about the prospect that we're hearing and seeing people that are showing that actually working. So.
Yeah, absolutely. All right, I think we've got one more clip on Fire APIs.
Hi, I'm Linnell Dent at Blue Cross Blue Shield Association. I'm part of the Health IT Interoperability team at the Blue Cross Blue Shield Association and also on the HIMSS24 board. One of the things that we're seeing in terms of the changes in healthcare and how they affect delivery is the fact that these APIs make it easy for a consumer to actually have the same information that the provider and the payer have, so that there's an opportunity for all three parties, the consumer, the member, the patient, the payer, the care coordinator, and the provider, are all working off the same amount of data to make the changes to improve their service, delivery, and care coordination.
All right, can we do little hearts for Linnell?
Yeah, seriously. So Linnell is actually my brother in arms in this work that we do out in industry. So it's like we share a brain. I mean, I just think that, again, I think he's restating, I think, some of the points that I've made here, but I just think that we're at this point, and we just had a conversation this morning about some planning for the fall. First, I just want to give Linnell huge credit for the work that we're doing. Like, he is such a change agent and just a convener, like his personal sort of ability to bring together the payers and the providers and over in Gravity, sort of the community members. I hats off. He does not get the credit in industry that he deserves for his own personal movement through the world. It's really remarkable. But I think that it is literally individuals that are making this change happen and showing it and creating the patterns, so that other people can look up from sort of their busy world and say, how can I do this? Oh, look, somebody else did it. Why can't we do it? And I think that's it's really part of, if you're a Malcolm Gladwell fan, right, that tipping point that we're getting to of, really anyone being able to make these changes and adopt these technologies in their local practice and partnerships.
Yeah, absolutely. I don't think there's anyone I talk to that I say, hey, do you know Linnell? And they're like, of course I know Linnell. So absolutely. And I think, his focus on the patient, right, and how important that is. So yeah, absolutely agree with everything you said. All right. So now we're going to switch to my favorite topic, pharmacy interoperability. And let's listen to a couple of clips on that.
Hi, I'm Melanie Marcus, the Chief Marketing and Customer Experience Officer at HIMSS24. We're in a place right now in healthcare where we've got major shortages in primary care. I mean, if you look across the country, we looked in our data at SureScripts, and we can see that almost 2/3 of counties in the country have less than one primary care provider per 1,500 population. That's incredible. And in 50% of those counties, there is enough pharmacy presence to allow pharmacy to at least take some of the pressure off high counties in those counties. And those pharmacists are all pretty much trained to do some of these base care delivery type things that would happen in primary care. Could be an immunization, it could be a blood pressure check, could be just a test for example, COVID, which they've been so great at during the pandemic. And so pharmacy is really positioned well to play a role in evolving an expanding care team and allow our country to have access to the care services we need. While pharmacy does that, a few things need to happen. First, they need to get aids to do that work. And so policy, payment would really play a role to allow that expanding care team to actually happen. And then second, they need access to the health information that's required to provide some of those services. And that's where interoperability comes in. And the role of bringing clinical information into the workflow for the pharmacist is very important to allow pharmacy to play a role for our nation in providing base healthcare and primary care.
I love that these are all our people. So yeah, I think everything that Melanie said, it's something we talked about. I was on a panel with Dee Davis and with Greenway and talking about pharmacy interoperability, right, and how important it is, especially in those pockets, those rural areas where there isn't a provider. We talk about this all the time, is what information do we have to get to that pharmacist, because they're essentially, in some cases, providing some of those primary care services for the patients. And again, goes back to kind of the things that we were talking about at the beginning of, meeting people where they are, what information do they need? They don't need the entire medical record for the patient, right? They may need some information. I talked to, Direct Trust about their ADT notifications, notifying, right, the pharmacist that one of their patients is getting discharged, and especially in those rural areas where they may be the only person that can actually go and, do some of these testing, making sure that they have their meds, all of that. So, I think that is such an important topic, and we're starting to see, right, focus on this. The fact that we had our ONC High Tech, the task force focused on this. It's interesting. We're actually meeting with EHRA this week to share some of those recommendations, because the EHRs are realizing too, right? Like, what can we do to step up to kind of meet some of this? I talked to a lot of HIEs while I was at HIMSS. A lot of them are like, wow, we never thought about pharmacists, or we can't get pharmacists on. And it just makes me take a pause, right? Because these are kind of barriers that I think we can easily overcome. And, back to our first comments about, we've got the technology. Now, what do we need to operationalize all of this? So I think it's really important to start talking about that.
So I love Melanie and sort of the SureScripts team, because I think they're so pragmatic. Like, there's a sort of been there, done that, right? Because of the maturity on the pharmacy side about how can we extend and sort of leverage sort of that experience and that strength, but that they apply, I would say, sort of their participation in the industry in a very pragmatic way, right? They're not doing far future things. They're doing things that are really attainable. I think that the sort of the theme I think that's coming out of our conversation and sort of folks' quotes today is this idea about, really understanding that the ecosystem is made up by all of these members of the care team, and sort of how do they all get equal access to the right information at the right time with the right consent and the right sort of narrowness of the data to be able to really take so much friction. And, we talked a lot over the last week, especially with the long-term care community, that stuff literally just falls to the ground right now. So how can we stop that patient experience from being this start-stop, very burdensome activity that it is today? And I think that, there's people out there willing to sort of pick it up and run with it. So.
Yeah, absolutely. All right. I think we've got one last clip on pharmacy interoperability that we'll take a look at.
Hi, I am Catherine Ayers-Wickenhauser, Senior Director of Community Strategy at Direct Trust.
So for advancements in technology for pharmacy interoperability, pharmacists are absolutely critical to the delivery of care, and we absolutely need to advance interoperability with pharmacy. And I'm interested in seeing what we can do from Direct Trust perspective, from the direct secure messaging perspective, to also work with pharmacists. For instance, ADT notifications, I know that has been a topic of conversation with pharmacy. So what can we do to advance interoperability? What standards and networks can we continue to promote to help with pharmacy interoperability?
Direct Trust, another one that we, I think we actually heard at the long-term post-acute care listening session, right? Like, people are using direct messaging in what you just said, right? To make sure things don't drop on the floor. And I think, what Catherine said is spot on, right? So it's funny, because when we started talking about pharmacy interoperability at NCPDP and care coordination, I had several pharmacists come up and say, hey, we're using direct messaging, right? And so again, I think this focus on meet people where they are, what are the tools we have? And I think direct messaging often gets, unfortunately kind of pushed to the side. It was something that, EHRs had to incorporate years ago when I was, doing MU certification. I remember having to certify for direct messaging. And so I think this to me is such an important theme that we need to keep remembering. I mean, you and I work in this world, right, where we're, kind of on the cutting edge. We're working with folks that are, very ahead of the game, but let's take a pause and think about all those people who are still, using direct messaging, using the tools that are actually working today to exchange this information. I don't think we get enough focus on that.
I think this is really important to sort of maybe bring us 360 from the beginning of our conversation and sort of the themes we heard coming out of last week, right? We have a really interesting sort of catbird seat, right, in a lot of this activity, but there's a realness to stuff that's installed and in place out in industry. And there's a reality that there are people that have access to capital and investment and technology resources and folks that sort of have to use what's built into the tools that they're already paying for, right? And that their tech budget is probably already higher than they want it to be, right? Or that they're completely tech poor. How do we meet them? How do we focus on content? How are we getting the business problems or the patient care problems solved with the right tools? How do we let people know that there are patterns out there that they can follow so that person that can get the direct message can do the same thing that the person that's connected to the HIE to the person that has a Fire API into a custom app inside of their data warehouse, right? From a payer perspective can do, because we have to meet all of those people. And how are we creating the vision or that picture? How are we creating the populace, right, in sort of inside of our market for people to know what they should be asking for, right? If we think about ourselves and our smartphones, how do we know that I want online banking? I don't want to have to go try and figure out how to get out of work by 2:00 on a Saturday or, by 5 p.m. on a Monday because I need to make a deposit in my bank. How do we build that sort of same expectation or meet that expectation, I think, that exists, especially in younger generations, for their healthcare interactions, but whether it's the business interactions or whether it's us as consumers and users of U.S. healthcare, that they're the same. And so again, tipping point, we're not there yet, but I felt like HIMSS delivers, I think, a sort of a veil pullback to say, who is doing stuff for real and what is still sort of like in the ether, not real, and you can tell it isn't real by people's talk track on stage, that I think allows us, I feel like, to come away from this past week and our time at Vive this year saying like, no, it actually is happening. This is actually taking traction.
Yeah, absolutely. All right. Well, I think we are at the top of the hour. So in closing, I just want to thank my POCP co-host, Jocelyn, Keegan, and, special thank you to all our colleagues who made time to speak with us at HIMSS, and big shout out to Melissa Bundy, who helped us arrange all of this. I think it's our first time doing this. I think it was a lot of fun, and I think we can hopefully continue this in the future at other conferences. But yeah, we survived another year of HIMSS and looking forward to 2025. So in closing, if you're a listener, thank you for listening to our podcast. You can listen to us on Apple Podcasts, Spotify, or whatever platform you use to pick up your podcasts, including the Healthcare Now radio. We also post videos of our podcast episodes, sometimes longer versions, on our POCP YouTube channel, which I'm assuming we're going to do, especially for this one, since we've got clips of folks. And in closing, don't forget that Health IT is a dish best served hot.
Is it a challenge to stay on top of interoperability regulations and the flurry of activity with fire accelerators? Email us at interoperoutlook@pocp.com to learn more about our new Interoperability Outlook subscription monitoring service.